in our body. Let me explain you first this thing and function of the ERNI, and then we will discuss about why we cannot do the BNP levels in ERNI, because actually ERNI or the neprilysin, we have two systems in our bodies. One is the RAS system, which actually increases the blood pressure. Increases the blood pressure by increasing this the heart failure. How? RAS system increases the renin, and renin increases the angiotensin and aldosterone, and aldosterone increases obviously the sodium and the water retention of our body. Again same, the angiotensin increases the sodium and the water retention in our body. So if we block here this angiotensin with ARB, it means we are blocking the heart failure, we are blocking those substances which are actually culprit and which are actually causing the increased sodium and water retention in our body. So we are actually decreasing the heart failure. Okay, so we block here the RAS system by ARB. Then another system in our body or our heart has natriuretide peptide system, NPS, natriuretic peptide system. This is a system which actually beneficial for our heart. This is a system which is actually opposite to the RAS system. This is a system which actually decreases the sodium and the water in our body, and it excretes the sodium and water through the urine by natriuresis. Okay, as its name tells itself that it is a natriuretic peptide system. So the natriuretic peptide system does what? It gives pro-BNP. It secretes pro-BNP, and pro-BNP divides or cleaves into two things: anti-terminal pro-BNP and BNP. This BNP is actually degraded by, like very rapidly degraded by neprilysin, and BNP is actually beneficial for us because BNP increases bradykinin, and by increasing the bradykinin substance P, and it secretes those substances which actually increases the vasodilation, increases the natriuresis, increases the H2O excretion in the water, and causes the diuresis, and it increases and it decreases the blood pressure and decreases the sympathetic tone of our body. So what we do by blocking the neprilysin, actually we are increasing the BNP. So by increasing the BNP, we are getting this beneficial effect of this drug or this component. So there is nothing to done with the anti-pro-BNP. So if you want to do something to check the heart failure or to exclude the heart failure in the heart failure patient who are on the ERNI, who are on the drug of an angiotensin receptor blocker and neprilysin inhibitor, so you have to do the anti-pro-BNP, because anti-pro-BNP has nothing to do with this neprilysin. But as your patient would have heart failure, it would get the more stretch on the atrial tissue, it would secrete the natriuretide peptide system and pro-BNP, and if pro-BNP would be released more, then you would get the more anti-pro-BNP. So the anti-pro-BNP is actually gives us a true measurement and a true picture of the heart failure. But because you are giving the ERNI, so if your any patient which is on the ERNI, they would have high BNP, because we have blocked the neprilysin which is actually increasing the BNP. Because of this, it's beneficial things. That's why it is a more important here. If your patient is on ERNI, then you have to done what? You have to do anti-pro-BNP but not BNP. Now the other factors which you actually if you want to do are soluble ST, cystanin and galectin 3. These are the actually advanced markers of heart failure. I don't think so that we should discuss these things now. The important thing which we actually want to discuss here, the obviously simpler things always remain simple, as we discussed about the CBC, UC, and we have discussed about the creatinine and all these things, and now we have to discuss about the ECG. What ECG you can get the ECG? Obviously you have to think about sometimes the fancy diagnosis. You can do the fancy diagnosis by the means of very simple investigation, such as sarcoidosis. You can get the pseudo infarct in anterior leads with sarcoidosis in sarcoidosis patient. Obviously if your patient is young enough, or if your patient has a history of if the family history of sarcoidosis, or if your patient has no history of the ischemia, but your patient is presenting with a dilated cardiomyopathy and you are finding the pseudo infarcts in the anterior lead, so you can suspect or you can make a differential diagnosis or a working diagnosis of sarcoidosis. But what else you can get in the ARVD patient and arrhythmogenic right ventricular dysplasia patient? You can get the epsilon waves in V1 to V3 in the right precordial leads. So ECG is actually very important, and sometimes you have the dyssynchrony like LBB pattern in which the QRS width is more than 120. So it is actually the poor prognostic marker of heart failure, and this thing actually shows that you can give, and these are the appropriate patient for the device therapy, like for cardiac resynchronization therapy, which we will discuss later on in the segment of treatment. So but you have to check the ECG, you have to get done the ECG in your heart failure patient to rule out all these things, to see the ECG, that what ECG is saying about your patient, because it may give the clue towards the diagnosis or towards the etiology of heart failure, and it may supports you and it may help you in the management of your heart failure patient. Because if your patient has LBB and like all these things, or if your patient has any like bradycardia, tachycardia, or if your patient has any sustained ventricular tachycardia, so you can diagnose your patient accordingly with those ECG findings. What else? Now the most important investigation is echocardiography, and there are the some parameters, a prognostic marker which we can discuss here with echocardiography. What prognostic marker you can get through the help of echocardiography. Now echo, okay. So in echo, obviously most of the time you would get the segmental wall motion abnormalities with low ejection fraction. Low ejection fraction is the essential prognostic marker in the heart failure patient. Okay, one thing. Second thing, if your patient has a segmental wall motion abnormalities, then you may clue your, as we discussed in our last lecture, that about the differential diagnosis of on the basis of findings and symptoms in heart failure patients. Or if your patient has a segmental wall motion abnormalities, so most likely your patient has coronary artery disease, okay, but your patient may have the dilated cardiomyopathy such as sarcoidosis, because in sarcoidosis you may get the segmental wall motion abnormalities. In Chagas disease you may get the segmental wall motion abnormalities. So you have to exclude other causes as well, okay, but echo can give you a clue and can give you a direction to do the investigations or to get the etiology of heart failure. Okay, one thing, obviously echo gives us the clue towards the diagnostic criteria, towards the diagnosis, and second thing, obviously echo helps us in in two segments, like for two things. One is diagnosis and other is prognosis. Now we have to discuss the prognosis, how echo would help us in the for the prognosis of in our patient, because there are the some parameters on echo which tells us the prognosis of heart failure. The important one is EF, which we have discussed here. Number 2 is LV mass. Number 1 is EF, we have discussed it. Now the LV mass. The LV mass is the important prognostic marker. So the LV mass more than 95 in women and more than 110 in men. 15 in men is poor prognostic marker of heart failure. And if you actually want to calculate the regional wall thickness, it again tells us about the prognosis and how you would calculate it. 2 multiplied by posterior wall thickness divided by the end systolic volume and diastolic dimensions. So if you calculate the posterior wall thickness, 2 multiplied by posterior wall thickness divided by the end diastolic volume, if that would be less than or equal to 0.42, it means your patient has a poor prognosis in heart failure. So we have discussed ejection fraction, LV mass, regional valve thickness, and now we have here another thing which I want to discuss with you guys is myocardial performance index, TI index, myocardial performance index or TI index. So what is the TI index? TI index is actually we have to calculate this TI index through tissue Doppler. Okay, so machine would tell you about the TI index of the LV. If it is more than 0.77, then your patient has a poor prognostic marker. Then it is actually poor prognostic marker. So if the TI index is more than 0.77, it means your patient has poor prognosis. And other things which we can do with the echo is the measurement of the diastolic dysfunction or the diagnosis of diastolic dysfunction. So we will discuss this with the in our topic of diastolic dysfunction. Now remember one thing, that ejection fraction, the prognosis of ejection fraction is actually depends upon the calculation of ejection fraction. There are so many methods to calculate the ejection fraction on echo, but the most specific and the most scientific and the most approved method according to the American Society of Echocardiography is Simpson methods, biplane Simpson methods. Okay, so just remember the name. What else we can do in our patients is CMR. Obviously in the certain etiologies, if you are suspecting your patient a sarcoidosis and amyloidosis, you have to get done the CMR, and on CMR you have to check the enhanced gadolinium if your patient has enhanced gadolinium. So obviously just remember few things about the CMR in the heart failure, that there are the few suspected cases, or if you are doing work on the diagnosis or the suspected diagnosis of sarcoidosis or amyloidosis, then you can go for the CMR. We have another study, SPECT study or PET study. You can check the viability in you know that the most common cause of the ischemia is coronary artery. The most common cause of heart failure is ischemia or the coronary artery disease. So if you want to check the viability in the hibernating myocardium, then you have to get done the SPECT or PET test. Okay, so you can check the SPECT test and the PET test. So these are actually the things. What else you can do? We will discuss all these things, SPECT and PET, in detail in the topic discussion of the thallium scan or the myocardial perfusion scan. Okay, and we have already discussed this thing in our ischemia chapter. That's why I just do not want to make it very lengthy over here. So right heart cath, there are a few indications of right heart cath in the heart failure. Number one is cardiogenic shock, acute cardiogenic shock. You have to get done the right heart cath to check the cardiology, cardiac transplant, or any need of cardiac mechanical circulatory support, and your patient has despite of pharmacological therapy, refractory heart failure. Despite of pharmacological therapy, your patient has refractory heart failure, then you can go for the right heart cath. Okay, and for again, if you have any confusion about the hemodynamics or etiology, or if you just want to check the hemodynamics of your heart failure patient, then you can go for the right heart cath. Now, what you will get on the right heart or in the heart failure patient? Obviously, in the heart failure patient, you would, number one is cardiac output. You have to check the cardiac output in your patients, because if for the heart failure patients, the cardiac output must be decreased in the heart failure patient. So how you would calculate the cardiac output? By two methods: thermodilution, and second is FIC. FIC is the most important and commonly used method. What is the formula of FIC method? Is cardiac output is equals to O2 consumption divided by systemic oxygen minus pulmonary oxygen. Let me write here: cardiac output O2 consumption, systemic oxygen minus pulmonary oxygen, multiply by 1.34 multiply by hemoglobin and multiply by 10. So that is the formula of, just write it down, jot it down in your notebook. So this is the formula of the FIC method to calculate the cardiac output through right heart cath. What else you can do? You have to check the pulmonary catheter wedge pressure. Pulmonary catheter wedge pressure tells you the obviously etiology, because in heart failure patient you would get always the pulmonary catheter wedge pressure more than 15 millimeter of mercury. And what else you can do in your patients? Right, RA pressure. Obviously RA pressure is an important indicator of heart failure. So what would you do with the RA pressure? You would calculate the RA pressure to PCWP ratio. RA pressure to PCWP, pulmonary catheter wedge pressure ratio, and that if that ratio is more than 0.63, it means your patient is in heart failure and is a poor prognostic marker for the heart failure. And you have to, if the RV work index, and if the RV work index is less than 400, then again it is the prognostic and diagnostic marker of your heart failure. So these, just remember these values, these are very important values for your patients. Okay, if you are going for the heart failure, right heart cath in the heart failure, then you have to check the few things. Number one is cardiac output, number two pulmonary catheter wedge pressure, number three is right ventricular index, work index, and number four is right RA pressure and RA pressure to pulmonary catheter wedge pressure ratio. Obviously you have to get done the coronary angiography to check, as you know that the most common cause of the heart failure is nothing but coronary artery disease. So if your patient is high risk and you have intention to revascularize your patient, so obviously you have to get done the coronary angiography. But the coronary angiography, the indication of the coronary angiography remains same, which we have discussed in the stable ischemic unit. Okay, so you must listen that, then you will get about the whole concept of doing the angiography in our patients. Okay, what else we can do in our patients is endomyocardial biopsies. Obviously, if your patient is heart transplant and he or she is presenting to the heart failure, then you have to get done the biopsy, which we will discuss about these things in the heart transplant chapters. Here the amyloidosis is the thing which amyloidosis and giant cell myocarditis. Okay, giant cell myocarditis are two main indications of doing the endomyocardial biopsy in the heart failure patient, because in amyloidosis there would be the generalized infiltrative disease in heart failure patient, but in sarcoidosis you will get the patchy involvement of the myocardium. So in sarcoidosis there is a very there is almost no indication of doing the biopsy, but these investigations, as we discussed, cardiac MR and all these things. But if your patient is amyloidosis or giant cell myocarditis, then the doing of the biopsy is better, and here the doing the risk versus benefit is like you can say that there is more benefit than risk of doing this biopsy in these diseases. Okay, what else you can do? The CPET, most of the time CPET we don't do the CPET in the heart failure patient on the routinely, but there are a few indications of doing the CPET. What is the CPET? It is cardiopulmonary exercise testing or embolic stress testing, cardiopulmonary exercise testing. Okay, and here we actually see few things, and first of all the indication of the CPET. There are few indication of the CPET. If you want to exclude the cardiac or the pulmonary causes, if you have any confusion between the pulmonary versus cardiac causes of the heart failure, then you have to get done the CPET. Second, if your patient is candidate for cardiac transplant, if your patient is a candidate for mechanical circulatory MCS support device, okay, then these are the actually indications in which you can do the CPET. Now in CPET you have to see the few things. Number one is VO2 consumption, maximum oxygen consumption. So normally our patients have 80% of the predicted consumption and more than 80% of oxygen consumption. Okay, but if your patient has VO2 less than 14 ml and less than 50% of predicted oxygen consumption, then your patient is candidate for cardiac transplant. So if you cannot do the cardiac transplant, at least do the mechanical circulatory support or do something to improve the functional class of your patients. Okay, second thing we can do here, the ventilatory anaerobic threshold, and third thing is VVCO2 ratio and VVCO2 ratio. This is actually ventilatory anaerobic threshold versus ventilatory carbon dioxide ratio. If this ratio or the slope is more than 35, it again gives a clue that your patient has a poor prognosis and you have to do something for your patient, or if you have to do something like the cardiac transplant. The most important marker or the most important thing which actually our professor or our examiners ask us, that is this VO2 consumption, actually, or oxygen consumption, maximum oxygen consumption. Okay, just remember that if it is less than 50% and less than 14, just remember this number 14. If this is less than 14, then obviously your patient needs what? Cardiac transplant. Or last but not the least, here is the sleep study in those patients who are actually the patients of obstructive sleep apnea. You know that the obstructive sleep apnea is one of the important cause of right heart failure and those patients of heart failure. So you have to do the sleep study, and if your patient are diagnosed as obstructive sleep apnea and your patient have the symptoms of heart failure, then you have to obviously give them the traditional therapy of heart failure according to their ejection fraction. Second thing, you have to advise them the CPAP. continuous pressure airway, positive airway pressure during their sleep. It actually increases the quality of sleep and the quality of life in those patients. But the one indication, the one thing which is contraindicated by American Heart Association is adaptive seroventilation. Adaptive seroventilation, it is actually contraindicated, but give the CPAP and the conventional therapy of your heart failure patients according to the ejection fraction of your patients. Okay, so get done the sleep study. If your patient is diagnosed as a obstructive sleep apnea with heart failure, then you have to treat them like this. And if you want to learn more about it, then please consult the pulmonologist. Here we have done the investigations and sign and symptoms. Inshallah, in our next lecture we will do about the treatment and the poor prognostic markers of heart failure. And inshallah, the coming lectures would be the last lectures of heart failure. Take care, subscribe my channel, press the bell button for the future updates. Allah Hafiz.